At ESMO 2022, we have had the presentation of two very important trials in the neoadjuvant setting. This comforts the very important role of acting early when the tumor is still present before surgery. There are two positive trials. The first one is the SWOG 1801, comparing pembrolizumab in the adjuvant setting versus the neoadjuvant setting. This was the first report. And the second trial was the T-VEC in the neoadjuvant setting, where this was the final analysis that was presented this year at ESMO. We have had the first report of the SWOG 1801 trial that was presented by Sapna Patel. This is a very interesting trial that tested a neoadjuvant versus an adjuvant approach in melanoma, stage 3B and higher, up to 4 were investigated. Patients were randomized between a neoadjuvant approach with 3 cycles of pembrolizumab prior to surgery and then follow up pembrolizumab up to 1 year, versus the standard of care that will be surgery first and then adjuvant pembrolizumab. And the results were extremely impressive because there is a hazard ratio of 0.59 in favor of the new arm, the neoadjuvant arm. The hazard ratio on this is on the event-free survival. And this is really remarkable because pembrolizumab per se in the adjuvant setting already has a very decent hazard ratio to placebo. Importantly, there was a 20% complete pathological response in the neoadjuvant arm. This is very interesting. It's to put in perspective with the complete pathological response that we have with CTLA-4 plus PD-1, which is higher. So this is an open question. What will be a similar study where there is a CTLA-4 PD-1 backbone in the neoadjuvant, something to be investigated in the future. Clearly, in terms of toxicity, there was no signal. There was absolutely the same tolerance in both arms, so which was, of course, expected. Taken collectively, these data are really thought-provoking. It's true that most patients are coming with a sentinel lymph node, so those patients need to be palpable nodes. That's not the majority of patients, but for this patient population, these results are really compelling to go for the neoadjuvant. We have had the final report of the trial that compared T-VEC in the neoadjuvant setting versus surgery alone for patients with melanoma stage 3B up to 4M1A. This was presented by Reinhard Dummer as the final analysis. This trial compared 6 cycles of T-VEC in the neoadjuvant setting prior to surgery. Then the rest of treatment was per standard of care in the local setting versus surgery and standard of care in the local setting. And the results are extremely interesting because all the metrics, the relapse-free survival, event-free survival, the overall survival, the distant metastasis-free survival, all turn out to be positive in favor of the new neoadjuvant treatment arm, which is of course extremely interesting. The reason being that there is a promotion of an immune response by this compound when injected locally intratumorally, which is the mode of action of T-VEC. So this study reinforces the idea that priming the immune system when the tumor is still present is probably a very good opportunity. Of course, it shows that T-VEC in the neoadjuvant setting is better than just the standard arm. Now, of course, we have to compare this with the other neoadjuvant strategy, for example, the SWOG trial, where this was pembrolizumab given in the neoadjuvant versus the adjuvant setting. So I think there is still a lot of work to understand what is the best strategy globally, but nevertheless, I think those two trials really now show the strong benefit of acting at the neoadjuvant state in melanoma.